Hello, KJR readers. I'm Jiyoung, the first author of our research titled Technical Feasibility of Quantitative Measurement of Various Degrees of Small bowel motility using Cine MRI. It is an honor to share our findings with you. Intestinal dysmotility is characterized by impaired contraction or relaxation of the intestinal wall and associated with various gastrointestinal diseases such as irritable bowel syndrome and chronic intestinal obstruction. Historically, several conventional techniques have been employed to assess small bowel motility. However, these approaches have limitations due to their poor reliability, lack of standardization, invasiveness, exposure to radiation, and anatomical complexity of small bowel. Cine MRI using balanced steady-state pre-precession per sequence has emerged as a non-invasive method for directly visualizing small bowel motility with good temporal resolution. Typically, radiologists qualitatively evaluate bowel motility on Cine MRI. However, quantitative measurement using optical flow-based technique has been devised. Previous studies using this technique have demonstrated reduced bowel motility in patients with Crohn's disease or chronic intestinal obstruction. A negative correlation has also been identified between disease severity and small bowel motility in Crohn's disease patients. However, these studies primarily focused on the clinical utility and compared the difference in motility according to the presence of disease. The technical feasibility of this method in evaluating various degrees of small bowel motility remained unexplored. Therefore, our study aimed to draw a quantitative score of the small bowel motility using Cine MRI and to evaluate its feasibility in measuring various degrees of small bowel motility. We enrolled 213 patients suspected of having Crohn's disease who underwent Cine MRI between November 2020 and July 2021. After excluding 39 patients unable to hold their breath during imaging acquisition, 174 patients were finally included in the study population. In our institution, we administer scopolamine and butyl-bromide, commonly known Buscopan, at a dose of 20 mg as an antispasmodic agent during routine MR angiography. This agent is administered twice in split doses of 10 mg to reduce the motion-related artifacts before acquiring T2-weighted and enhanced T1-weighted images. Our experience has shown that a single initial dose of Buscopan does not yield full antispasmodic effect, leading to diverse degrees of small bowel motility. To capture a diverse range of motility, we intentionally conducted Cine MRI about 5 minutes after the initial dose of Buscopan. For Cine MRI technique, we employed two-dimensional balanced turbo field echo of Philips with a temporal resolution of half a second per imaging, generating 45 images over 22 seconds. Given the absence of a definite gold standard for measuring bowel motility in Cine MRI, in our study, two radiologists independently evaluated bowel motility using a three-grade system. Grade 1 indicated an adynamic or non-peristaltic wave. Grade 2 represented decreased but preserved peristalsis, and Grade 3 signified normal peristalsis. They are representative cases of each grade. Discrepancies between readers led to the creation of two reference standards. One is a 5-tiered grading employing mean values, and the other is a 3-tiered grading employing consensus grades after re-evaluation of the discrepant cases. For quantitative assessment, one radiologist manually drew the small bowel region on the final Cine MRI frame, following a 1-month washout period. After selecting a reference image, non-rigid registration was implemented in a multi-resolution manner. With an iterative optical method, we estimated time-varying displacement fields through the time series of Cine MRI. At each pixel, the standard deviation of the time-varying displacement field's Jacobian determinant was computed, and the mean metric within the drawn ROI was determined as motility score. To assess motility score reproducibility, a third radiologist independently outlined the small bowel area for 60 selected participants, leading to the independent motility score calculations. We analyzed the interoperable agreement using weighted kappa. The correlation between motility scores and qualitative grades using Spearman's correlation coefficient, and motility score reproducibility using the intraclass correlation coefficient. Diagnostic performance for determining small bowel motility grades was evaluated using ROC curve and the area under ROC curve. These are results. The darkest green cells indicate concordant cases, while the lighter green cells represent discordant cases. There are a total of 48 discordant cases. It is noted that cases with a 2-grade difference between two leaders did not arise. The weighted kappa value showed a lower margin of substantial agreement. The MVs were 1 in 15, 1.5 in 12, 2 in 44, 2.5 in 36, and 3 in 67 participants. The theses were 1 in 22, 2 in 75, and 3 in 77 participants. Motility score reproducibility was excellent with an ICC of 0.987. These are motility scores aligned with qualitative grade. Based on the MV as a reference standard, mean of motility score was 0.019 in grade 1, 0.027 in grade 1.5, 0.033 in grade 2, 0.032 in grade 2.5, and 0.043 in grade 3. Based on the CZ as a reference standard, mean of motility score was 0.020 in grade 1, 0.032 in grade 2, and 0.042 in grade 3. Both MV and CZ demonstrated a significantly positive correlation with quantitative motility score. This is a RLC analysis to determine each grade based on the MV. For determining MV of 1, the AUROC was 0.953 and optimal cutoff stands at 0.024. Sensitivity and specificity were 100% and 89.9% when using the optimal cutoff. However, performance was lower for determining MV of 1.5, 2, and 2.5. In the same analysis using CC, diagnosing CC of 1 showed an AUROC of 0.962 with optimal cutoff of 0.025. The sensitivity and specificity were 100% and 89.5% when using the optimal cutoff. The performance was also lower for diagnosing CC lower than 2. Our study has some limitations. First, we included only participants suspected of Crohn's disease, potentially introducing selection bias. However, it's important to emphasize that our study's focus was not to represent a specific clinical cohort, which mitigates the relevance of this selection bias concern. Additionally, we excluded cases with a respiratory motion artifact, which might introduce an additional selection bias. Furthermore, evaluating global motility as a single grade was challenging, especially when different segments of the small bowel showed varying degrees of motility. Finally, the degree to which the motility score would characterize the various motility patterns of the small bowel remains uncertain and warrants further evaluation. In conclusion, the motility score calculated from Cine MRI allows for the diagnosis of a dynamic small bowel and shows promise in evaluating different degrees of small bowel motility. Thank you for your attention.